I am Professor Dr. M.J. Ajam, Scientific Secretary of Bangladesh Society of Cardiovascular Intervention. Welcome to all this wonderful BSCI initiated webinar. Very good evening to everybody. Really, it's my honor and privilege to introduce our President, Professor A.K. Fazlur Rahman sir. He is the President of Bangladesh Society of Cardiovascular Intervention. From the consent of our President, I just introduce our international faculties, as well as our interested speakers. So, he is the fourth President, Bangladesh Society of Cardiovascular Intervention. He will chair our today's session. And it's my honor and privilege to introduce my co-moderators, Professor Mir Jamaluddin. He is the Secretary General of Bangladesh Society of Cardiovascular Intervention. Currently, he is the Director of National Institute of Cardiovascular Disease. Next, our Professor Fazilatunisa Malik, who is the Scientific Chair of this Bangladesh Society of Cardiovascular Intervention. He is the Chief Consultant of National Heart Foundation. All of you know very well everybody, and third, me also part of moderation in the single events. Next, I can introduce our Professor Antonio Colombo. As we know, as you know everybody, working for success will make you a master. But working for satisfaction will make you a legend. So it's my privilege to introduce legend like Dr. Antonio Colombo, who has enormous contribution in the development of field of interventional cardiology. He is the author, he is the legend, and I believe his name is itself enough to introduce himself. Next, I can introduce Professor Tang Hui Chim. He is the Bangladesh-friendly interventional cardiologist and the key opinion leader in the Asia, not only Singapore. He also visiting professor of 13 university in the Asia. He is the currently president of the Singapore Heart Foundation. Now I introduce my friend Dr. Shaoliang Chen. He is the professor. He is the inventor of the DK cars, you know, DK cars technique, and he is the chief principal investigator for the definition to trial. Today, we have not only international speakers, also international faculties, like from Ramesh Singh from the Malaysia, and Dr. Hee Hua Hu from Singapore, and Krisida Memek from Thailand, and Dr. Hu Ya Hu Chen from Hong Kong, Dr. Lee Yi An from Vietnam, and Dr. Anil Misra from India. And our expert panel from Bangladesh, key opinion leader, Professor Subir Rahman. He is the first president of Bangladesh Society of Cardiovascular Intervention. And next, Professor Dr. N.M. Momiud Jaman. He is the second president of Bangladesh Society of Cardiovascular Intervention. And third, Professor Afzalur Rahman. He is the third president of Bangladesh Society of Cardiovascular Intervention. And today we have Professor APM Shohruzzaman. He also chief consultant of the Levitt Cardiac Hospital. He also with us. And next, I introduce Professor M. Maximul Haq. He is the chief consultant and professor of cardiology in Ibrahim Cardiac Center. He is a very popular teacher in our country. And next I go for Professor Dr. Atar Ali. He is very, very popular in our all fellows, especially he has tremendous contribution in the heart failure patients. And today this is our agenda. We just changed some of our events because of our, as you know, Professor Shaoliang Chen is busy with his primary PCI call. That's why we reshaped. First talk will be given by Professor Dr. Antonio Colombo on drug-eluting balloon, where we stand today and what around the corner. And then this session is moderated by Professor Mir Jamaluddin sir. He will moderate the session after inauguration of our president. Then second session is little will change. Which technique is to be used, it can be shifted in the third session. So session 3 will be 2, definition 2 trial. Main results is be covered by Professor Shaoliang Chen after Colombo. After Shaoliang Chen, Professor Tan Hui Chim also covered left main bifurcation, which technique we should use. Dear colleagues and wonderful friends, as you know, our patients and physicians expectation a lot. Our patients try to get their less symptoms, try to live longer, and try to stay out from the hospital with the minimum cost. And our physicians' expectations to give the best treatment for our patient with the best, for best outcome. So that's why our BSCI, these objectives enhance our understanding, advance in interventional therapeutic approach in small vessel disease, and the essential technique based on current wealth of evidence for the best outcome for the left main interventions. Finally, practical ways essential small vessel disease, especially in bifurcation treatment, can be implemented to benefit patients. Now I'm requesting our Professor A.K. Fazlur Rahman sir to inaugurate the session. After inauguration, our Professor Mir Jamaluddin sir will moderate our first session. Thank you very much, Professor Fazlur Rahman sir. Could you please start or inaugurate the session?
Yes. Thank you very much, Dr. Azam. Welcome you all to BSCI International Webinar 2020, organized by Bangladesh Society of Cardiovascular Intervention and supported by Beximco Pharma and Concept Medical. It is an honor and privilege that to have us world-recognized speaker among us. I am happy to introduce Antonio Colombo from Italy, Professor Tan Han Sem from Singapore, and Professor Xiao Ying Ling Chen from China as our international speaker.
Unmute. আমারটা তো আনমিউট করা নাকি প্রফেসর প্রমার
And today we have the opportunity to exchange our knowledge and learn from experts from home and abroad. Dear friends and colleagues, I hope today's webinar will be a memorable one from which we will be benefited in many ways. So now I request our Honorable Secretary General, Bangladesh Society of Cardiovascular Intervention, Professor Mir Jamaluddin, Director National NICBD, to continue this session. Thank you all.
Fazlur Rahman, Professor of Interventional Cardiology, Bangabandhu Sheikh Mujib Medical University, as well as our President of Bangladesh Society of Cardiovascular Diseases, to give me the opportunity to have welcome to all the international speakers, international and national panelists, and the participants. Good morning, and for someone, good evening. It's my pleasure to have all the international faculties as well as speakers to have in our conference of Bangladesh Society of Interventional Cardiology. It's remembrance of Professor Abul Hossain Khan Chaudhary. He is my direct teacher, and he was the one of the renowned interventional cardiologists of Bangladesh, and he was the ex-director of National Institute of Cardiology. He died during COVID era, and we pray for his departed soul for heaven. We have the executive committee of 27 members, out of which 6 are vice presidents and 6 are members, and all others are directors, all others are secretaries of different faculties, and our ex-officio Professor Afzalur Rahman, who was the immediate past director of National Institute of Cardiovascular Diseases, as well as immediate past president of Bangladesh Society of Cardiovascular Diseases, and ex-officio Kaisar Nasrullah Khan. Now, I want to introduce you Antonio Colombo, who will have the speech on who will have the speech on DCB or drug-eluting balloon, where we stand today and what is around the corner. And Antonio Colombo, General Coordinator of GBM Care and Research Group, Cardiac Laboratories, Italy, Director, Cardiac Catheterization Laboratory, Columbus Hospital, Milan, and he has been one of the early initiators of TAVI procedures in Italy, refining some aspects of the procedure. Antonio Colombo is on the editorial board of all major cardiology and interventional cardiology journals. He received several recognitions, including the TCT Career Achievement Award and PCR Ethica Award. He published more than 1,000 papers, and he is the Professor San Rafael Scientific Institute as Professor of Cardiology for last 20 years. May I request Professor Antonio Colombo for your speech.
Hello, hi. Thank you very much for being part of this meeting, and good afternoon to everybody. I'm going to share my screen, and you let me know if you see my presentation. Should come out. Okay. Can you see? I'm going to go in the presentation mode.
Yes, we are seeing.
So DCB, drug-coated balloon, where we stand today and what is around the corner. I think drug-coated balloon have an important future, and I will go over various aspects where we believe drug-coated balloon should be utilized. I have no conflict to disclose regarding this presentation. First of all, and I will devote not many slides to this topic because DCB for ISR is a quite accepted modality. We know that a second DS is effective, but we would like to limit the amount of metal put on top of each other. This is a recent analysis, comparison of new generation drug-eluting stents versus drug-coated balloon, a meta-analysis of randomized controlled studies published in the British Medical Journal. And these are the various studies, basically the RIPS, quite a relatively large sample size, not a lot, but overall we go more than 300 patients if we put together, and there is angiographic and clinical follow-up, so the data are important. And overall, we must say that for TLR, the second DS is superior, for MACE as the same. But why we still believe that drug-coated balloon are a good modality, even if this meta-analysis seems to go in the opposite direction? We believe in that because we think that lesion preparation is essential. And if you do not have a good result after lesion preparation, you should implant a stent. So you cannot assume the drug-coated balloon is always effective. This is a good study from the German group in Munich, where they compare drug-coated balloon following lesion preparation with angiosculpt in yellowish and without angiosculpt lesion preparation. You see a insignificant difference in diameter stenosis at 6 months, and more important, the binary stenosis goes down from 32% to 18%. So if you do a good lesion preparation, and we don't use much angiosculpt, we use more cutting balloon. And if we do not have good lesion preparation, if the result is not excellent, we go over to DS implantation. But if the result is good, we go to drug-eluting balloon or drug-coated balloon. In some situations, in extreme situation, we even combine the drug-coated balloon with the DS. We know that there are patients with diabetes that have multiple restenosis, patient on dialysis, or patient with severe renal failure that are prone to sequential restenosis. In this group of patients, we utilized in the past Paclitaxel eluting balloon and in the same session a drug-eluting stent. We have published about 57 lesions in 46 patients. Now we have much more with a follow-up at 1 year and acceptable TLR, 5%, 7% target vessel, MACE 11%, and we have no event of thrombosis. So this is a niche procedure, but in some patients may be important. Another area where we believe that drug-coated ballooning is important is small vessels, not in stent restenosis, just small vessel. Basket small, it's a very important study published in Lancet 2 years ago. 758 patients comparing to Taxus and everolimus, mainly 75% were everolimus. The MACE rate was similar, 7.5, 7.3, cardiac death. Basically, even the numbers are 2 times is not different, and very low stent thrombosis, 3 cases versus 4. So I believe in vessels smaller than 2.5 or 2.5, the drug-coated balloon is a very good choice. Gives you short duration of DAPT, and according to this study, 758 patients gives a very good long-term outcome. And I believe if you extend the follow-up, the difference will become most probably significant in favor of the drug-coated balloon. But now I want to go to something that I called a novel approach to limit stenting. New generations interventional cardiologists are taken by long stents. They stent from healthy to healthy. And in my view, this approach is not always the preference. So we say that following a pre-dilatation, if you have a poor result or a bad dissection, you should stent. If you have an optimal result, you may consider to use a drug-coated balloon and no stent. If you are not sure, we suggest to measure the pressure gradient, and if you see that the pressure gradient is low, we don't have solid data, we will do a study. But if the pressure gradient is less than 10, I think you can safely go to drug-coated balloon. We now have a series of cases where maybe in some situation we implant a short stent and the rest is a drug-coated balloon. I'll give you some examples. This is a right coronary artery, total occlusion, reopen. We implant a drug-eluting stent in the proximal part, and all the distal part is treated with a drug-coated balloon. And you see here the result, and the follow-up in this case was excellent. And we are collecting cases where instead of doing a full metal jacket, we take this approach. Stent in the focal part, a drug-coated balloon in the other segment. Here you see an LAD and the left main with a severe stenosis, and diffuse disease in the distal LAD. This was done with stenting in the proximal segment, everolimus eluting stent, and in the distal segment, we use a drug-coated balloon. And this limits the full metal jacket, giving the opportunity of stents to give their action in a big proximal part of the vessel and drug-coated balloon in the more distal. This is another example, diffuse disease of the LAD, subtotal occlusion in the distal. Most of the time, you will approach this case with a full metal jacket, and we don't think it's such a good idea. So this was pre-dilated. We had to use cutting balloon because it was a high pressure, etc., etc. We did IVUS. I just go quickly. Whatever, we did lithotripsy because the balloon did not expand, then cutting balloon. So finally, we did optimal lesion preparation, and this is after optimal lesion preparation. And in this case, we stented only proximally and distally. Even if there is this dissected vessel, we did not stent. What we did, we measured the distal pressure in the very distal part of the vessel with a pressure wire, and the distal pressure was acceptable with a gradient. Are you sure? We have contrast FFR of 77 with a difference in the pressure of 15 millimeter of mercury, which is very acceptable for such a distal LAD. And then we did the drug-coated balloon with the final result, as you see, with only one short stent proximally and nothing distally. This is the final result, and this patient did very well, and we are collecting several patients with this approach, utilizing distal pressure to support the idea not to stent the dissection. Here, the pressure gradient was only 6 in the proximal part. In the more distal part was 87, so 13, and we did not proceed with any stent. So, we have published in the past a series of drug-eluting balloon plus DES with a clinical follow-up. A lot of diabetics, 46% were diabetics. This is an old publication, but we are still collecting cases now. We are over 100, and we compare the result with a similar series. We utilized the drug-eluting stents, and you see that the target vessel revascularization was the same, 14, 11%, without having the need to do a full metal jacket. We do not like these results. This is a full metal jacket of the LAD that after years became aggressive restenosis. We should come away from this approach. This is not elegant at all and is not good for our patients. Look at the LAD totally occluded. If you reopen this LAD, it will close again. This is a patient that cannot be treated. And unfortunately, the operator even put a longer stent on the OM, making another full metal jacket. We believe that this approach should be abandoned, and we need to move to more elegant way to treat our patient and not to give them to this long-term chronic disease, which is chronic in-stent restenosis. So to conclude, I believe DCB are effective for treatment of ISR only after optimal lesion preparation with the possibility to cross over, I would say 20 to 30% if you do not achieve optimal lesion preparation. DCB can be used to treat a small vessel disease with some advantages compared to DS, such as short-term DAP, and the paper in Lancet supports this finding, and the new concept, and we hope to provide data utilizing an appropriate strategy. A drug-coating balloon can be utilized to treat long lesion, limiting stent lengths with no stent or only a short stent in the more proximal part of the lesion. Pressure gradient should be considered to evaluate the result and to give security to the operator and to the patient about not treating even a dissection. Thank you for your attention.
Professor Colombo, thank you very much for your talk on the DCB and sharing with us your novel way of treating the small vessel and diffuse disease using the pressure wire. I just want to ask, in terms of lesion preparation for small vessels, because we have a lot of diabetes in Asia where vessels can be very small, 2 or lower. So any special balloon you use for the lesion preparation? Because I don't think we have a cutting balloon that is 2.0. So what's your advice on the lesion preparation?
But I think cutting balloon is available for 2.0. Is available. We use a lot the cutting balloon, and we go to high pressure with the cutting balloon. What is important with the cutting balloon is to take into account that when you go to high pressure like 18 or 20, becomes semi-compliant. So you have to undersize the cutting balloon 0.5 millimeter. If you do not have the cutting balloon, you can use a scoring balloon or the non-compliant balloon. These are, but the cutting balloon for 2.0 vessel is available, and we use it very effectively. Sometimes, even when you have a 360-degree calcium, you may have to do rotablation before, but this approach is very effective.
Thank you, Professor Antonio Colombo, for your brilliant speech. In our daily practice, we get more than 30% of our intervention is of small vessel. But which one is the most important, or which one is the most specific treatment of small vessel disease yet to be determined? And small vessel disease, treatment of a small vessel disease or angioplasty of the small vessel disease is a bit challenging due to small caliber. There is much more dissection, there is perforation, and these are the challenges of small vessel intervention. So we have not yet confirmed which procedure is most appropriate, but the recent trials shows what you have shown in your first slide, the basket 2 small trial. They have shown almost similar effect, and in other trials recently, JET has published in 5th May 2020, they have published papers on this drug-eluting balloon on ISR, and drug-eluting balloon on bare metal stent ISR. The result of drug-eluting balloon and new ISR, a new drug-eluting stent is almost same. They have also shown that the drug-eluting balloon, in the case of restenosis of drug-eluting stent, is also almost same to introduce another stent. In the field of small vessel intervention, if we can avoid the stent, then we can preserve the artery armor as normal, and avoiding the long-term dual antiplatelet therapy, as well as we can avoid the thrombosis. May I request Dr. Ramesh to have comment on this topic?
Yeah. So first of all, I think when it comes to small vessel disease, we have to make sure it's actually truly small vessel disease, and I think for that you need imaging to ascertain it. And if indeed there is actually small vessel disease, there are many options for you to prepare your lesions. For example, I use the Scoreflex NC balloon, which can actually go down all the way to 1.75 millimeters. And you can actually take it up to very high levels, pressures of 22, 24, 26, without fear of actually perforating the vessel. So that remains a challenge. I have a question for Professor Colombo, actually. Professor Colombo, many years ago, you came to my institution, and I remember that you used quite a bit of drug balloons here, and you actually inflated the drug balloons for between 3 to 4 minutes, and you are very comfortable with it. What is your current practice now? How long do you usually, assuming the patient is stable, how long do you actually inflate your drug-coated balloons actually, and or at least what is the minimum time that is required?
The minimum time is 45 seconds. But we usually inflate, if the patient tolerates, for 1 minute, then we deflate and we do a second inflation for another minute to really, there is no study, but to optimize the result and drug delivery. We inflate the balloon at 10 atmospheres. We don't go very high pressure because these balloons are semi-compliant. So 1 minute usually, and if possible, another second inflation at 1 minute.
Thank you.
Thank you, Dr. Ramesh. And now may I request Professor Subiar Rahman, Professor Emeritus, and she was the first or founder president of Bangladesh Society of Cardiovascular Intervention, ex-director of National Institute of Cardiovascular Diseases, as well as ex-advisor of Ministry of Health and Family Welfare. May I request Professor Subiar Rahman, Madam.
Good afternoon, everybody. It's nice to see you all in good health. And I don't know whether you all know it or not. I went to Professor Colombo twice for hands-on training a long time ago. Whether he has remembered me or not, I'm not sure. When I was young, I went there. And first time I went with Mr. Qasim and the Indian team. I was the only lady there, and he was really taking care of me and giving me a lot of chance to have a hands-on practice there. And first time in my life, I did the peripheral with him and the carotid as well. So thank you. Nice to see you, Professor Colombo. The presentation is as good as always as you do. But this drug-coated balloon I used some time ago when it was available in our country. There, as in ISR, I found it quite good, and also mainly is a small vessel. So what you have highlighted, I always tell my fellows that whether you are using a drug-eluting balloon or you are using a stent, you must prepare the landing zone. You must prepare the landing zone and prepare the vessel, and which you have also highlighted. So the balloon can be there, and then the coated balloon can be there. But before, when we were there, 1 minute, 2 minutes, you used to say 3 minutes and rotate the balloon. Do you still do that after 45 seconds? Colombo?
Can you repeat the question?
I say after inflating, first inflation in small vessels or ISR, you used to tell us that you inflate it, keep it 2 minutes or more than 1 minute definitely, and then deflate it and then rotate the balloon and do it again. Do you still recommend that?
Rotating, not necessarily. Not necessarily rotating. Doing a second inflation, yes. But rotating, I'm not so sure that is so important. Some people do that with the cutting balloon because they believe that rotating the cutting balloon, you cut in different positions, but I don't think it's so important.
So I mean, it's, what you have highlighted is we are always practicing it, but still, I think the vessel preparation for the landing zone for duct-coated balloon also to inflate, and also the stents to stenting. But your case is what is amazing, and the result is good. hope that when we'll do our cases here more and more, and result will be as good as yours. Thank you again, Dr. Colombo.
Thank you, Professor Suvia, madam. Comparison of drug-eluting balloon versus drug-eluting stent, they have shown in 23 randomized trials, they have shown the result of drug-eluting balloon and drug-eluting stent for small vessel is almost equal. But there are small vessel is also nowadays divided into small vessel and very small vessel. Very small vessel is 2.25 to 2 millimeter, and these very small vessels, what is your main strategy? Do you prefer, Dr. Colombo, Professor Colombo, do you prefer only drug-eluting balloon or the newer drug-eluting stent, 2 millimeter stent? Which one you prefer?
But I must tell you that in the last 4 or 5 years, I never implanted a stent smaller than 2.5. I do not like, of course, in Europe, we do not treat very, very small vessels like in your practice in Asia. So we are a little bit fortunate and gifted because we don't have these problems. But I believe that even if you have a dissection, we have to understand which is a dissection which is malignant and which is a dissection that we can live without stent. And angiography is not always the best way to evaluate the type of dissection. That's the reason why I like to use the pressure gradient. If I have a dissection and the pressure gradient across the dissection is low, less than 10, I will not place a stent and leave the dissection heal by itself. Sometimes will never heal, but the vessel will not occlude and will not restenoze. So I think it's not always possible, but I believe if you take this approach, you may limit 50% of the stenting in small vessel, because we know that when you place a stent in a small vessel, the restenosis rate is high.
Thank you, Professor Antonio Colombo, for your nice answer. We are very happy to know that only drug-eluting balloon is the best out of these two. Drug-eluting prefers you, but in US FDA have approved the 2 millimeter stent that is of Limus eluting stent Onyx, and they have marketed it, and they have told that this can be increased up to 3.25 millimeter. And so if the vessel distal diameter is 2 and proximal is 2.5, 2.75 or 3, they can raise up to that. Now, may I now request our Professor N.A. Mominuzzaman, who was the President of Bangladesh Society of Cardiovascular Intervention and now is the Chief Consultant Interventional Cardiology of United Hospital. May I please, Professor Dr. Mominuzzaman.
Thank you very much. Actually, I'm not there to give any comment after the lecture of the legend Anthony Colombo. But just sharing my experience in terms of nowadays, because of the extensive use of drug-eluting stent, and in our zone, the nature of the disease is so much so, that barely you will find a place for the landing zone. So sometimes we need to put a long metal jacket, and sometimes the patient come back with a focal response. So in that cases, usually my practice is I usually don't use the cutting balloon. Rather, I use 2 wire and use a high pressure non-compliant balloon to inflate that area, so much so that there is almost zero residual stenosis, then I use drug eluting balloon, because many of these places is not completely expanded at the beginning. That's it, that need us for stenosis. So probably if you can expand the stent well and use the drug eluting balloon, then it gets a better result. But I'm very much impressed about the latest information that Tony Colombo said. Instead of putting a long stent, putting a drug eluting balloon distally and proximally with the drug eluting stent. That's a good idea.
Yes.
But I'm a little bit apprehensive because many of these small vessels, not only disease, also a lot of calcium. So sometimes there is a lot of dissection that remain. So what about that? Is there any chances of stent, chances of reocclusion of the vessel if I don't put any stent? This is my question to Dr. Colombo. If I keep the vessel being dissected, not being stented, that was the concept actually very beginning of the intervention, that to scaffold the dissected part with the innovation of stent came. But what will happen nowadays in a small vessel if I don't cover it with a stent? What is your opinion, sir?
As I said, I think we cannot leave a dissection without evaluating the dissection. In the past, we did not have a good way to evaluate a dissection except the angiography. Now, and I know that there is, you don't even need the pressure wire. There are some catheter you can put over the wire. There is one device from Assist and one device from China, where you have the microcatheter and you put over the wire and you can measure the distal pressure. And if you have a good distal pressure to the dissection, you can leave the dissection without a stent. If the distal pressure is low I mean there is a gradient more than 10, 15, 20, then you should place a stent. If you take this approach, the risk of occlusion is very, very small. Doesn't mean that you don't have to stent. You will still have to stent maybe half of the dissection, but half is not 100%. So it means that in many cases, you can leave a dissection without stenting, but not based on luck, based on scientific evaluation of the dissection.
What about your antiplatelet protocol for this sort of?
The antiplatelet is the same, 1 month if you do not place a stent, or 6 months at least if you place a stent. No difference.
Thank you, sir. Thank you, sir.
Thank you, Dr. N.M. Jamal, and once again, thank you, Professor Antonio Colombo, for concluding the session 1. Now we are concluding the session 1. Before the conclusion of the session 1, I can say one thing more, that we have seen our our mentor, Professor Sufia Rahman. She was once upon a time, around 2003-4, she did different types of angioplasty left main, and at that time she had done small vessel angioplasty with a stent. So far I can remember it was Tsunami. At that time, dilating stent was not also available in our country, and after that it was available. Then now I call the third session Professor M.G. Azam, Ghulam Azam, to start the third session, definition 2 trial, main results. Professor M.G. Azam.
Thank you. Can you hear me, sir?
Yes.
Okay. Thank you very much, sir. Now we go to, as you know, I told you earlier, we reschedule our program because of the primary PCA program in for Professor Sauliang Chen centers. So he will give his talk right now, definition 2 trial main result. As you know, he is the legend in the field of left main complex bifurcation PCI. He is the inventor of the decay crush technique, and he is the chief investigator for the definition 2 trial. And we believe this definition 2 trial give us significant insight how to implement in our clinical practice, especially left main bifurcation disease. As you know, in Bangladesh, it is very, very popular. Initially, we treat by bifurcation lesion by TAP or culotte. Nowadays, it is become very popular for decay crush. So I think Dr. Sauliang Chen give his talk, excellent talk. Can you share your slide, Chen, Dr. Chen?
Hi. Hi, thank you. Can you escape?
Sure.
Okay. Can you see my slides?
Yes.
Okay. Once again, thank you very much, all my friends. Thanks Professor Azam to invite me to present the main results of the definition 2 trial. It's a randomized multi-center study to compare systematic two-stent technique with provisional stenting approach in patients with complex coronary bifurcation lesions. This is my disclosure. Basically, so far there are a few randomized studies to compare two-stent with provisional stenting technique for coronary bifurcation lesion. Roughly, all the randomized study could be divided into European-based RCT and also a few decay crush serial trial. From European-based randomized study, Antonio is here. He's a PI of CAT study to compare provisional with cassette crush. At 1 year follow-up, there was no significant difference in 1 year MACE. Another European-based study is the BBC-1, also comparing provisional with the two-stent technique. Still, the negative results was reported. So from this study, you can see that we can conclude that the provisional stenting technique is much better than two-stent technique. On the other hand, from our decay crush series trial, particularly from our decay crush 2 and the decay crush 5 two study comparing provisional with the decay crush, finally we got lower TIR rates in decay crush group from our decay 2 study. From our decay crush 5 study, only included distal left main true coronary bifurcation lesion and 1 year follow-up. In decay crush group, the TVF rate was pretty lower than provisional stenting technique. So on the right arm, we can conclude the decay crush is much better than provisional for coronary bifurcation lesions. Why there is so wide discrepancy between European-based clinical trial with our decay crush serial trial? So probably lesions complexity is correlated with a clinical outcome. Once again, let's take insight analysis from the European-based clinical trial. You can see from Cactus study, the side branch lesion length was around 8 millimeters. According to QCA, side branch baseline diameter stenosis was around 60%. However, from BBC-1 study, the side branch lesion length or side branch baseline diameter stenosis was not reported. Another European-based study, Nordic study, also comparing provisional with two-stent technique. The side branch lesion length varied from 3 millimeter to 11 millimeter. Another very interesting thing that from this study, the side branch lesion length is around 11 millimeter in two-stent group compared to very short 3 millimeter side branch lesion length in one stent group. The side branch diameter stenosis was only around 40%. From our DK patch study, you can see from DK2, the side branch lesion length was around 12 mm. Side branch baseline diameter stenosis was around 65% according to QCI. Again, from our DK patch 5 study, side branch lesion length was around 60 mm. So from this slide, we can get our preliminary conclusion that probably there is a significant difference in lesion complexity between different clinical trials. However, there is no prospective randomized study to define the bifurcation lesions complexity. I also know any data to support the correlation of lesion complexity with worse clinical outcomes. In 2018, ESC studied that complex coronary bifurcated lesion could be defined as side branch diameter minimal 2.75 mm, side branch lesion length longer than 5 mm. Also, if prospective difficulty to access the side branch after main vessel stenting. These three items for the definition of complex bifurcated lesion has never been confirmed from any clinical trials. So I think it will be very important for us to define a criteria to differentiate simple from complex bifurcated lesion. In 2015, we combined our Chinese centers database together to establish this definition criteria. So from slide you can see if a bifurcated lesion localized at the distal left main, side branch lesion length minimal 10 mm, and the side branch diameter stenosis minimal 70%. This is a major criteria for distal left main bifurcated lesion. Besides it, we also provide 6 minor criteria to support the prediction of the lesion complexity. 1 major criteria plus any 2 minor criteria. So the bifurcated lesion could be defined as a complex bifurcated lesion. This is a definition criteria derived from one validation group and tested in another study group with a large number of patients with Medina 111 and 011 and 2 traditional true coronary bifurcated lesions with side branch diameter minimal 2.5 mm. It means this criteria probably not suitable for small side branch bifurcated lesions. So from table you can see, even we only use the major criteria, side branch lesion length minimal 10 mm and baseline side branch diameter stenosis minimal 70% for distal left main bifurcated lesion. The sensitivity and the specificity is very high, more than 70%. So this is the aim of our definition 2 trial, because the complex coronary bifurcated lesion defined by definition criteria has never been tested in a randomized study. We tried to compare the treatment effect between provisional and 2-stent strategy in patients with real complex coronary bifurcated lesion defined by definition criteria. Inclusion criteria is similar to previous bifurcated study. Particularly, you can see acute myocardial infarction older than 24 hours prior to treatment was also included in this study. Again, similar to our previous study, only Medina 111 or 011 true coronary bifurcated lesions were included in this study. There was no significant difference between exclusion criteria in this study and our previous bifurcated study. The endpoint was a 1-year tight lesion failure TLF. Assumption was that the 1-year TLF rate was around 14% after provisional stenting technique and 7% after systematic 2-stent strategy from our definition study, and also we published DK-3 or DK-5 study. Finally, a total of 660 patients was required in order to achieve 80% power to study alpha 0.05. So this is the study flowchart to show finally there were 325 patients in the provisional group and another 328 patients in the 2-stent group. safety endpoint was a stent thrombosis rate at 1 year follow-up. Angiographic follow-up was scheduled at 13 months, 1 month after 1 year clinical follow-up. So baseline characteristic table show a very high rate of MI older than 24 hours in both groups. There was no significant difference in terms of the multiple clinical characteristics between two groups. From the lesions distribution, you can see almost 29% of complex bifurcation lesion localized at the distal left main. The mean main vessel lesion length was longer than 40 millimeters. Particularly, side branch lesion length was around 20 millimeters in two groups. Multivessel disease was pretty high in two groups. Even all lesion could be defined by operators as a complex coronary bifurcation lesion, but reassessed by co-label, it was a 91.2% in the two-stent group and 94.2% in the provisional group. Mostly are Medina 111 true coronary bifurcation lesions in two groups. So most procedures were done from transradial approach because of the very severe plaque burden in two groups. So a side branch pre-treatment in provisional group was very common. It was around 46%. Finally, two-stent technique was used in 92.1% in the two-stent group. The crossover rate from provisional to two-stent in provisional group was 22.5%. So in two-stent group, DK quality was mostly used in 77.8%, and the Q-law was used in 70.9% in the two-stent group. In the provisional group, of 73 patients underwent two-stent implantation, TAP was high use. It was 64.4%. After two-stent technique, final kissing balloon inflation was pretty high used in the two-stent group. Unfortunately, in two-stent group, after final kissing balloon inflation, part technique was only used in 88.9% in the two-stent group, even non-significant to 91.4% in the provisional group. But this result rests one concern about the routine use of part technique after two-stent technique. So at 1 year follow-up, the primary endpoint of tight lesion failure was 11.4% in the provisional group, significant difference to 6.1% in the two-stent group, mainly because of the high rate of TLR and target vessel myocardial infarction in the provisional group compared to two-stent group. On the other hand, there was no significant difference in terms of the secondary endpoint, including all-cause deaths, cardiac deaths, and definite stent thrombosis. So survival curve showed very, very significant separation of two lines immediately at 7 days after index procedure because of the early occurrence of tight vessel myocardial infarction. After 7 months follow-up, you can see two lines continue to separate each other because of the increased rate of TLR in the provisional group. I think it's easily to understand. So in conclusion, systematic two-stent has less rate of 1 year TLF for patients with definition criteria defined complex coronary bifurcation compared to provisional approach. It may suggest the benefit of DK quality for such a particular complex coronary bifurcation lesion, but the underlying mechanisms for the high rate of target vessel myocardial infarction after provisional stenting are unclear, and a full study is warranted. Thank you very much. Thanks for your attention.
Thank you, Chan, for your brilliant presentation.
Thank you.
Actually, we know, especially in case of bifurcation lesion, left main or non-left main bifurcation lesion, it is really a tough job to make a decision whether true bifurcation lesion or pseudo bifurcation lesion. especially in true bifurcation lesion, we definitely take a decision either we should go for provisional stenting or double stenting strategy. And now I request Professor Maximul Haq, would you please make any comment, or would you like to add any comment regarding especially distal left-brain bifurcation strategy? Professor Maximul Haq, can you unmute?
I have a question.
Good afternoon, ladies and gentlemen, from Ibrahim Cardio Hospital, Dhaka, Bangladesh. Special thanks to Antonio Colombo, Professor Tan Shim, and Shawn Liang Shen, and also the panelists from India, Malaysia, Thailand, Singapore, Hong Kong, and Vietnam. First of all, I'm a very great fan of Professor Shawn Liang Shen. In fact, when DK Crash 1 was published in A, it showed final kissing balloon inflation was possible in 100% of cases compared to about 75% in classical crash. And I think from that moment, I got interested in DK Crash. And subsequently, the other publication up to DK 5 and also 6, they convincingly showed that DK Crash seems to be better. And unlike European studies where provisional stenting is better unless, as you have said, that the size of the side branch is more than 7.5 or lesion length 5 millimeter, or there's a chance of occlusion of the side branch. In other cases, you do provisional stenting. But this recent DKCAS trial has challenged this concept because 1 year data is very convincing. However, there is no significant difference in stent thrombosis and cardiac death. The mechanism, as he has said, that increased macular infarction in the target vessel in the provisional stenting group is unclear to me, where some of the theories are shear stress and other things, which I really do not understand how it increases the macular infarction. The two interesting points to me for newcomers in bifurcation stenting is, one is that side branch occlusion is almost nil in DK Crash. That is very important because we know the scenario, if a side branch is lost in a left main stenting, whoever the operator is, that is a panicky situation. And in the side branch occlusion in the provisional group in this trial, definition 2 trial, is almost about 10%, and of which around 10% could not be salvaged. So if it is a large branch, this is a situation which the operator doesn't want. And in that situation, I think DK Crash is user-friendly, at least for the immediate outcome. And 1 year outcome is also good, as he has shown. Another thing for hospitals like ours, even though we have imaging facilities, but because of cost issue, we cannot use in all cases. And in this study, only about 25% of the cases they have used imaging, as I have read, about 27%. And even with that, the result is good. That is a good point. But this study was basically not targeted to study DK Crash versus provisional stenting. Rather, it was two-stent strategy versus this provisional stenting. So we really cannot conclude that from this study that DK Crash is better for these complex lesions. Finally, several ongoing trials are going on in Europe, especially the EBC main trial, which is looking at provisional versus systemic. And yesterday, I just listened to one of the Goran's lecture that early next year, the publication, these results will come up. But we should all remember that this trial was done by experts who have been doing this study, we've been doing this procedure for at least 10 years. So even probably we cannot replicate these results. So let us wait for an independent replication of definite 2 trial till a final conclusive comment can be made. Thank you, Dr. Shawn Liang, for your excellent deliberation.
Thank you. Thank you for your comments.
Thank you, Professor Maximul Haq.
I just want to ask you one question. If I'm not wrong, that I read in the paper that in some cases of 2-stent strategy, the second stent could not be deployed.
Yeah.
This is one of my questions. And second question is, do you think that if imaging could be used in most of the cases, then the results could have been different?
Yeah, thank you for your question. It's actually, for some very extreme cases with very ridiculous angle, so it's not easy to deploy second stent in the side branch. I think this is true. So we have explained in our Topic-5 trial why there is almost 9% of side branch stent could not be advanced into side branch. This is true. But from our definition 2 trial, the failure rate of using second stent in side branch was lower than that from our Topic-5 study. Second question about the use of IVUS. This study was conducted at 49 international centers. For some European centers, they are reluctant to routine use IVUS because they have IVUS eyes. Second reason will be the cost effective. I think in some centers, IVUS is not routinely used. So these are two reasons for low rate of IVUS use. For this issue, now our another study, Topic-8, is ongoing to compare IVUS guided and angio guided Topic technique. So we try to get the difference between IVUS guidance and angio guidance. Thank you for your question.
Thank you, Professor Maximul. Thank you, Professor Maximul Haq. Now, actually, in especially left-brain bifurcation technique, popularly we believe provisional stenting strategy is most of the country or outside all over the world mostly preferred provisional stenting, and especially subset of complex BCI, special cases we should consider double stent strategy. And I believe Antonio Colombo is here. Colombo will at some point. Actually, he is the initially he is very much fond of culotte. What about your opinion, Dr. Colombo, regarding distal left-brain bifurcation?
But as we already said, you should use 2 stents when the side branch is diseased and is large, more than 2.5 millimeter. We are not against 2 stents. We don't believe that provisional is a solution. Provisional when the side branch is small and when the disease is focal. Otherwise, 2 stents. And we use the crush. We promulgated the crush. DK crush is better because makes the opening more reliable. And we are happy that finally there is some trials that demonstrate what we were thinking for years, even 6-7 years ago. We placed 2 stents when you have a side branch which is 5 millimeter, 10, 11, 12, lesion length, you know what I mean. You can come out with 6, 7, 12. I like the definition of Dr. Chen regarding complex side branch. I compliment him because it's a very good definition of complex side branch. So this should guide the decision to go with 2 stents.
Thank you, Colombo. Actually, when we decide go for elective double stent strategy, then we should prefer DK class, no doubt about it. Some extent, if the vessel morphology may gives you clue which technique you should prefer. But first of all, our recommendation to our fellows, which technique you are familiar and you are confident you must go, then you go for complex strategies. But I think Chan will make us clear, in case of provisional stenting, when you go for first stent, when you need for second stent, go for the side branches painting, then which technique then you should follow? Other, because there is no chance for DK at that time. So would you prefer, or what is your recommendation at that time?
Oh, very, very good question. So before answering your question, I need to tell you two very famous slogans by Antonio Colombo. One day he said, cancer crash died in Europe, but DK crash survived in China. Same thing is that, the TAP technique is innovated by Dr. Antonio Colombo. I feel my personal experience and also my knowledge probably is limited, but I highly recommend once you deploy the main vessel stent and you need to use the stent sub-branch, I think TAP is much popular, is my favorite. But here I have one question. It goes for Antonio. So for simple coronary bifurcation, have you finished a randomized study to compare drug eluting balloon with the two-stent technique?
I think it would be a good idea to do a randomized study, but we need to have a way to evaluate the result on the side branch. If after pre-dilatation and kissing balloon and having placed a stent in the main branch, the side branch shows a good result, I believe you can enroll in the randomized study of drug-coated balloon versus a second stent. If after kissing balloon inflation, the side branch is not a good result, I think you should not use a drug-coated balloon, but you should go immediately for a stent. But if the side branch has a lot of disease and the side branch is complex, then you have to go to the provisional, and then you pay the price of occlusion, etc. So I think if it's a left main, I will be a little bit reluctant. If it's in a different bifurcation, maybe. But for the left main, I prefer security of two stents.
Yeah, exactly. For this left main bifurcation, really it's not rare. After provisional stenting technique using one stent, one day patient probably will die without unknown reason. Good. So Professor Azam, my colleague has called me 2 times, so can I leave for label to do primary PCI? I'm so sorry.
Sure. You can join for primary PCI. Thank you very much, Dr. Chen.
Thank you, our friend.
Now I'm requesting our Professor Attarali. Please, would you make any comment for this bifurcation trial study? Have you any recommendation, Professor Attarali? Sir, can you hear me, Professor Attarali?
With us?
Yes, he is with us. Professor Attarali.
Yes.
Okay, if I think he is not available, now I can call Dr. Misra from India. He has a tremendous experience on left-hand bifurcation. Would you please make any comment from this?
Right. Thank you for inviting me for this as a panelist on this conference. And I must say, Dr. Chan talk was very interesting, and I congratulate him for undertaking a trial with such complex lesions. You can see these lesions were on average syntax score of 24 plus. They have a main vessel lesion, which is almost 24, 25, or even more longer. The stents were used up to 40, 42 millimeter. The side branch lesions were using almost 25 millimeter of stents, so they must be very long lesions. Almost quarter of them were main stem bifurcations, Medina 111, majority of them. And 80% or plus had multiple lesions, basically, not just a local bifurcation, they had multiple lesions. And 40% of them were calcified as well. So really fairly complex subset. And taking help of IVOS only in 25% of cases, that's another thing to see. I'm actually a big fan of DK crush. I have been using variety of techniques in past. I know DK crush takes much longer to do because their number of steps are much more. But if you see in studies, once you get used to it, even these definite 2 studies, if you see, the overall time taken compared to the provisional stenting group was only 12 minutes more. The overall dye load was hardly 12 milliliter more. And the overall cost of various equipment was perhaps just addition of one extra balloon. So they're not very expensive or very time consuming in that way. And once you master this technique, the success of crossing the side branch is not an issue at all. So that's very good. And not only the DEFINITE-2 study, even earlier, there are meta-analysis published of the bifurcation studies. Earlier, all studies were provisional stenting is better than 2 stents. But recently, last 2-3 years, there have been a number of 4 or 5 meta-analyses published, which included 4 or 5 trials where DK crush was used. So if you see this meta-analysis, DK crush came on the top. And very more recently, if you see in June JACC Interventions, June issue, you'll find a meta-analysis of about 5,711 patients where they compared the T provisional stenting, T with TAP, and crush, Coulet, and DK crush, whereas all other types of stenting had no difference in MACE compared to the control. But DK crush had almost 61% reduction in major adverse cardiac events and 63% reduction in target lesion revascularization rates versus provisional stenting. So that is fairly impressive. Now, in the current DEFINITE-2 study, we cannot really say which technique is superior to other because it was not powered enough to see which technique is superior to other. But I think with some backing coming up from the DK crush techniques, some meta-analysis coming, now DEFINITE trial, I think for left main bifurcation, DK crush is going to be the technique to use because that probably leads to the best results and covers all the complex situations as well. Yes, there will be some very small percentage of cases where you may only get away with provisional stenting, but usually left main is too vital a vessel, and often the lesions are complex involving the bifurcation, and side branch is also a very big important side branch usually. So gradually, I think more and more DK crush technique is going to be used in the side and left main depth bifurcation. But what about the bifurcation in the other vessels is still not. We have a complex set where we know DK crush seems to be better. But what about simpler lesions? We don't really know. In simpler lesions, is just provisional stenting better, or is it DK crush going to be superior in that as well? If you go by sort of the benchmark testings and you see the very nice videos inside the stent, you see DK crush seems to achieve excellent results and very, very, very nice results to look at. But whether it translates into good clinical outcomes is what we have to see. So I'm sure there are more studies coming. There is BBK3 study coming comparing Coulet with DK crush. We are having an EBC main study coming up, which will compare DK crush, TAP, and Coulet. So we will have some more information in the coming years. But yes, I'm a big fan of DK crush technique, and I tend to use it as frequently as possible.
Thank you, Mr. Now I can request Dr. Lee An from Vietnam. Would you please make one comment? After your comment, I know Professor Fuzilatunusam Malik will take the chair for continue the next session, and Professor Tang Hui Chim is the very, very famous for left main stenting, and he will give a significant insight which I already discussed. I think he will give the solution. Dr. Lee, can you add your comment?
Yeah. Hello, everyone. It's DEFINITE-2 trials. It contributes good evidence for bifurcation lesion treatment, especially in the Asia area. The people prefer BSCI to cabbage. So this trial, it's suitable for the side-branch bigger. It's 2.5 millimeter. So after that, I think if optimize the result, all the patient should be perform the IVERT or the OCT after procedure. And the second, I think this trial shows the kind of stent they use more because it's the design and characteristic of stent effect on the in stent or this in stent in the outcomes of trials. Thank you.
Thank you. Now I'm requesting Professor. Yes, sir.
Professor Azam, May I request Professor Fazilatul Malik to have a comment for the young cardiologist regarding this decay crash, as you have a large series of decay crash in Bangladesh.
Thank you for asking me to do that. But personally, I really enjoy doing DK Crash because what I feel is that it is like a recipe. So you just follow step after step. And for me, actually, with chronic kidney disease patients, I find that this is very useful because I don't use any dye. I like 30, 40 ml of dye is enough, because you just follow the steps and you go on looking at your hemodynamics and your patient. If they're stable, you just follow the steps and you just need dye very occasionally. And if you want, you can do imaging as well. And the results, usually the immediate results as well as the long-term results, are excellent. And once you get used to the technique, it is fairly easy to do. That's my experience. And in our hospital, we've done more than 110 DK crush till date. We started last year. Actually.
Thank you, madam. Now I'm requesting, please, you take the charge to continue our next session. Professor.
So
thank you, madam.
So thank you for giving me this opportunity to introduce Professor Tan Yu Ching. Actually, Professor Tan Yu Ching requires no introduction. He is one of the most talented interventional cardiologists of this region, and I could say maybe globally. And it is a testament to his genius that he is seen in all international congresses, where he's taking a very leading role. He is, as we all know, the director and senior consultant cardiologist of NUHS Singapore and the president of Singapore Heart Foundation. Not only is he a very dedicated interventional cardiologist, he is also a very dedicated and hardworking teacher. It is his passion to teach, and one of the indications of how passionate he is as a teacher, we can see by the fact that he is a visiting professor to 11 universities globally. Can you imagine 11? He is a passionate teacher, a passionate interventional cardiologist, and he is also, I'm proud to say, a very good friend of Bangladesh. He has visited Bangladesh many times. He has worked closely with us. He has held workshops, and it is indeed really gratifying for us today that he has joined us. He is renowned not only nationally as well as internationally, and in his country he is in high esteem. And that is reflected by the fact that he was awarded National Day Award for Public Service Administration in 2016. He was given the Ministry of Health Singapore Distinguished Senior Clinician Award in 2017 and the National Medical Excellence Award in 2011. So I could go on and on about Professor Tan Yu Ching, but I will end here and I will request him to give us his presentation. So thank you so much, Professor Tan Yu Ching, for joining us. So can we have Professor Tan's presentation?
Professor Tan needs to unmute himself.
So, Professor Tan, could you unmute yourself if you haven't already done that?
Can you hear me now?
Yes, we can. Thank you. We can. And
thank you very much.
Right. So thank you for joining us.
Thank you, Fazila, for the very kind introduction. It's a delight to be back again with all my Bangladeshi counterparts. I just recall 5 days ago, we were meeting in the IPDI meeting, and it's great to be back again. So the topic assigned is left main bifurcation, which technique to use. Just want to remind the audience that Dr. Andre Granzit's third PCI patient was a 43-year-old man with severe angina pectoris from a severe left main disease. And after his balloon angioplasty at that time, in 1977, we also know that the patient died suddenly 4 months after the procedure. So left main PCI is not a trivial procedure. We know also from the Excel trial that if you attempt a left main intervention, you better be ready for a distal bifurcation lesion, because 81% of AMI PCI in the left main are going to involve disease at the bifurcation area. And the treatment of left main bifurcation is a little bit different from the other non-left main bifurcation in the sense that we have a large side branch, which is the circumflex, which has a large reference diameter, and sometimes it can be very angulated, which make it difficult to access with guide wires. Secondly, the bifurcation of the left main stent really affects the implantation technique. Acute occlusion of the left circumflex usually results in considerable ischemia. And left main is the only bifurcation where the proximal main branch originates directly from the aorta, and this increases complexity because of the interactions with the guiding catheter, and also if the disease extends all the way to the ostium, it will be a challenge to manage lesion. Now, the other considerations include that the longitudinal compression during the left main stenting is very common, and when untreated, it can be associated with an adverse outcome. The proximal reference diameter of a left main sometimes can reach 6 millimeters, which is close to the dilatation limit of many coronary stents. So careful reference to any manufacturer's guideline is recommended. And also we have this phenomenon of a left main trifurcation, which are encountered in about 10% of left main cases. And this will require specific treatment strategies. All these are the unique considerations in a PCI of left main artery. I can say that as far as treatment of left main PCI is the same as all the other bifurcations PCI. There are three choices. One is just merely to keep the circumflex artery open without attempting to stent at all. Two is the provisional stenting, where you will reserve the option to stent the side branch if the need requires. And thirdly is go straight to a true stent strategy. So if you want to adopt or keep it open, typically this will be a side branch that is usually small and diseased and is not suitable for stenting or clinically not relevant. So in which case, then you just wire both branches, you dilate the main branch and you stent the main branch. And if you need to preserve the side branch, you may consider a balloon, but otherwise if it's just open, then leave it alone. So this is a keep it open strategy for left main. The second option is a provisional stenting. This is a situation where your side branch has disease at the ostium and where the side branch, when the side branch is suitable for stenting. And this option is probably the most commonly adopted techniques in the left main bifurcation. In about 60% of left main bifurcation, it can be treated using the provisional technique. This is a simple and fast technique, excellent short-term and long-term results, and you keep all the other options of two-stent strategy in case of failure of preserving the sub-branch. And I will not go into the step-by-step provisional technique, but suffice to say, you will put the two wires, you stent the main vessel, and then you might exchange the wire or you put in a third wire and do a kissing if you feel like doing it. If not, you just simply withdraw the wire and you're done with a provisional technique. But you will salvage and go for a two-stent in a provisional stenting approach when the following happen. When you have a significant side branch flow impairment of TIMI grade 3 or less than 3, you have a major side branch dissection, or when the side branch is diseased and large enough and then it's compromised following a main vessel stenting, leading to significant ischemia in which patients may have symptoms, or when you're so concerned after stenting the main branch that the future access to the side branch may be compromised, then you might want to consider a provisional two-stent strategy. So these are the various strategies that you can adopt in somebody whom you want to do a provisional second stent into the side branch. You can do a tap technique. This graphics tells you basically how it's being done, a tap technique or reverse crush technique or keloid stent technique. So all these options are available to you in terms of choices. But there are, of course, advantages and disadvantages with regard to each and every of this need. I want to go to a two-stent strategy now. And the two-stent strategy, I think the strategy of intervention really depends on the bifurcations of the lesion. And I would like to say that if the lesion is less than 70 degrees involving the two daughter vessels of a left main artery, more than 70, it will be a need for me. And if it's a less than 70, it's going to be a keloid or a DK crush technique. So when we talk about T-stenting strategy, this is something that's quite familiar. You put one stent in the side branch, and you come and put a stent in the main branch. The trouble with a class T-stent strategy is that sometimes you can miss the ostium of the side branch. And this can be a frequent source of restenosis and re-narrowing if you miss the ostium of the side branch. That's why people come up with this new technique called the technique. Where it's a T-stenting but with a little bit of small protrusion. So the techniques involve basically putting a stent into the main vessel, and then you dilate the main stent cells into the side branch. Then you put a stent into the side branch. You inflate the stent at the maximum pressure, and then you pull back a little bit of the balloon and do a kissing with a main vessel balloon that's already packed across the side branch, and then you finish up with this procedure. So that is a technique that you may consider as a provisional build-out strategy. And we know that when you do a kissing using a tab, in this bench study, it does not actually crush the stent that is protruding out. You basically create probably a little bit of a small new carina, but otherwise there is no crushing of the stent in this technique, in this bench study by Armstrong. When you have an angle of less than 70, there are two favorite approaches. I think the European loves tab and keloid. The Asian perhaps prefer DK crush. Keloid technique is something that is very familiar to most of you. It's described first in 1998 by Chevalier. It allows for an adequate osteo coverage both in the primary two-stent strategy, and you can also use it as a provisional sub-branch stenting technique. The proximal vessel to bifurcations have double layer sleeve of stent. This is the biggest difference compared to DK crush, where you have your double layer of stent on one side of the vessels only versus keloid, which is in the entire artery in the main vessel. The proximal ends of both the main branch and the side branch stents will need to be sized up to the proximal vessel. This is critical. So your main branch and the side branch need to be somewhat similar in diameter. And your stent design will have to have a cell space that can be expanded to the size and diameter of the side branch in this technique. Then we also heard about the DK crush earlier on from Dr. Chen, and this will be the 7-step procedure that he teach us all about. So it's a 7-step. If you would like to use an IVUS, it will be a 3 IVUS step as well in addition. So a side branch stenting first, followed by a balloon crush in the main vessel, followed by a first kissing balloon inflation, followed by a main vessel stenting, then you do a port, then you do a kissing, and you do a report. So in the 7-step DK procedure, crush procedure, you can complete. So the advantage of a DK crush, as we all know, is that it's a very effective technique. It is preferred to classic crush because in classic crush, you have trouble in crossing the side branch after you have crushed it with the main vessel stent in about 10% of cases. The disadvantages is that it cannot be performed as a provisional strategy. You're pretty much committed to a two-stent strategy from the very beginning, and it takes multiple steps, and few operators would have this experience. So there's a little bit of a learning curve as well. But when we compare the different types of stent strategy on left main bifurcations, let's look at some of the old data. The old data from BBK left main registry, which follow up patients on 10 years duration, comparing a single stent strategy versus a two-stent strategy of tab and keloid mainly, you find that in terms of target lesion revascularization, the two-stent strategy was much worse compared to the single stent. So the double stenting actually confer a higher long-term risk of MACE, but it's only in the first year because after first year, pretty much the same sort of curve. There's a higher incidence of target lesions revascularizations in the two-stent strategy. But when you look at modern stent trials, particularly looking at DK Crush 3, And DK crush is probably the most widely evaluated stent strategy, I think, to date in the left main bifurcation. When you look at a 3-year follow-up comparing crush versus keloid in the distal left main bifurcation, what is amazing to me is that you can see that there's a higher incidence of MACE, which is driven mainly by increased myocardial infarction and target vessel revascularization. And just look at the definite stent thrombosis rate. It was 0% in the DK crush group versus 3.4% in the keloid stent group. To you, this DK crush is kind of superior in the distal left main bifurcation. And the reason why it is so is at least shared a little bit on this bench study by Dr. Chen and his colleagues again. When you have a DK crush, you don't have this necking ring that you see in a keloid stent techniques. Whether this necking ring, which is present in the keloid and not in a DK crush, is responsible for the difference in terms of the clinical outcomes is it's at this point in time speculative. But we also know that there's a follow-up study of a DK crush left main. Now we look at the DK crush comparing DK crush versus a provisional approach. Again, the DK crush reigns supreme in terms of reduction of target lesion failure. But what is more interesting is that if you look at the target vessel myocardial infarction, is clearly lower in the DK crush, and stent thrombosis is clearly low again in the DK crush 5 study in the DK crush arm. So, but what is more interesting is that as a prelude to the definition 2 trial that was presented earlier on, in the DK crush 5, you only see benefit of a DK crush versus provisional in complex lesion and not in a simple lesion. So again, going according to our concept now that if it's a complex bifurcation lesions to begin with, then it's perhaps a better strategy to go for a 2-stent strategy from the very beginning. And this is indeed what the algorithm which was published in JAG intervention tells us in 2017. Once you have a very complex lesion, go straight for a 2-stent, preferably DK crush, that's recommended by the Asian Bifurcation Club consensus statement and supported by image guidance. But when you have a simple distal left main bifurcation and you think that you can access the side branch easily, then just do a provisional approach. But if you think you cannot access the side branch easily in case anything happened to the side branch, then better to go straight to a 2-stent strategy, even if it's a simple bifurcation lesions. I just want to highlight briefly the need for imaging and physiological assessment. Certainly, the use of IVUS or OCT can provide essential information for assessment and treatment of patients with this left main bifurcation. It provides better insight into the plaque configuration, and it can diminish the unnecessary use of a 2-stent strategy if you are able to define the extent of the disease. Image guidance can also improve outcomes and allow selection of appropriate stenting strategy. Certainly very helpful in terms of vessel sizing and identify calcifications that may need lesion preparation in the form of atherectomy. Since this is a study from Park, which tells us using image guidance, you can actually have a mortality benefit in patients who receive left main stenting. So this is something that I would encourage people to look at. And certainly from a physiologic perspective, there are at least 4 trials now to tell us that bifurcation and left main stenosis can be evaluated quite accurately with FFR when there are no significant stenosis downstream. And FFR-guided revascularizations can be safely applied to patients with bifurcation and left main stenosis and aids decision-making. All these 4 trials tells you that a deferral or maybe a choosing of a conservative approach for patients with a normal FFR is a safe strategy. And but IFR has never been evaluated in this setting. So in conclusion, Madam Chairman, ladies and gentlemen, I think the goal of PCI in left main bifurcation lesion is to attain an optimal results in the main vessel and maintain physiologic patency of the side branch. While provisional side branch stenting should be the default strategy for low risk, perhaps 2-stent strategy may be preferred for high risk or complex bifurcations in the left main. The DK crush techniques seems to be the most favorable, but keloid techniques are also excellent options. So the decision to which 2-stent strategy to use should be driven by bifurcation morphology, operator experience, and clinical trials. And finally, I will encourage the use of imaging and physiologic modality to save time and optimize outcomes. So with that, thank you very much for your attention.
So that was a great presentation as usual. Thank you so much, Professor Tan Yu Ching. Really enjoyed your presentation. So now I would like the panelists to make some comments. Please, it's an open house, and we are so lucky that we have such a wonderful array of panel of experts from all over the region. So I would first like to invite our guest panelists who have come from other countries and joined us virtually today. Please, if any of you want to make any comments or have any questions to Professor Tan Yu Ching, please do so. Just press on your mic and just join us, please. So anyone with any comments, please?
This is Yu Ho from Hong Kong. Professor Tan, very nice presentations.
Thank you.
I learned a lot from your presentations. So actually, I learned that DK crush. So nowadays, we all think that it is maybe better than TAP or culotte. But for the culotte, you mentioned that one of the drawbacks is the napkin effect. So therefore, I'm thinking that if we can pay more attention on the size stent cells expansion limit, which can avoid the napkin effect. Another thing is that I'm thinking if we could do DK double kissing culotte routinely, the results of the culotte technique may be improved because of the DK crush, DK culotte. So why do I say that? Because some of the bench tests say that if we do the double kissing culotte technique, the distortion of the stent can be diminished. And also, if, as mentioned, if I pay more attention over the size stent cell expansion limit, say if I know that the stent cells size of the stent expansion limit, say, is more than 4.5, then that may produce good results when we do the left main bifurcation stenting. So what do you think? Do you agree this kind of comments? I know that there is no randomized control trial, but to me, I think if we do DK culotte, the results may be even similar to DK crush. This is what I guess.
Yeah, so I know you are a champion of DK culotte, which is even less well known and familiar to many of our audience. Maybe one day you can share with us your DK culotte technique. But suffice to say, I think that if you are meticulous in whatever stent strategy that you use, it is likely that you will achieve excellent outcomes. If you pay attention to the size of the vessel, you pay attention to ensuring that apposition symmetry is ensure no dissection, and you achieve the best MSA possible with your techniques. I think you can achieve as good a results as with any technique. So, but until the randomized trial is carried out, like I say, I don't think we'll ever know whether DK crush is ultimate best or maybe DK culotte can also challenge in that sort of situations.
Very nice. Very agree with you.
So any more comments from other panelists?
Yes, Professor Chan, I'm always concerned in the culotte technique about a lot of metal hanging around in the main vessel, the double layered metal. So that is always a concern. So in the left main, which is a critical location, one would always be a little more concerned than other bifurcation lesions. But in practice, whenever there's an emergency, culotte is perhaps the easiest technique to do. So in the emergency left main situation, I would go for culotte, but in other all planned ways, I would go for DK crush.
Yeah, so I think you have to be very familiar with one or two types of two-stent strategies so that in emergency situations, you can always fall back on. The trouble with a keloid stent technique is that if your daughter vessel is much smaller than your main vessel, then you have a problem. For example, if your circ or LAD is very small compared to the left main, then you might have a sizing problem in that setting, and perhaps a DK crush might be better. But you're right, you have to fall back to something that you're most familiar with in an emergency situation.
So, but Professor Tan, one thing, now that we have these stents, which a 2.5, you can, make it up into a 3.5 or even a 4, maybe this issue will sort of become in the background once we use that kind of stent more and more. So even if there's a discrepancy in size between the daughter vessel and the mother vessel, we could maybe overcome it by using that kind of stent.
Yeah, so that actually helps a lot. But the trouble is that sometimes the discrepancy may be so large that you can't say, for example, a circ in a 2.5 circ and a 5 left main, then it becomes a real situation.
Absolutely, yes. Totally agree. Yes.
But you're right, this current new design does offer us a lot more flexibility.
Yes.
I mean, in practice, you'll have to have a side branch of almost 3.5, close to that, to be able to deploy a stent into the main stem as well. Because anything less than that, you may not match the main stem.
Dr. Tan, one question from Calcutta. In your practice, what percentage cases are provisional stenting and what percentage in two stent? And is it DK crush in most cases in two stent strategy in your practice? It is question from Calcutta, Dr. Vinayak Dev.
That is a good friend of mine, and so I would say that in left main stenting, I have to say that two stent strategy probably is is more prominent, more commonly performed. So when I do left main bifurcation, I would say that it's in excess of more than 50% that I do a two stent strategy compared to provisional approach. But everything where else outside left main, I think provisional strategy is my choice. And exactly which technique do I use? I watch the morphology and the angle, and I decide. So I could go DK, I could go keloid if it's less than 70.
Dr. Tan, then it is important is the angle as well as the lesion in the side branch, lesion in the main branch, as well as the size of the vessel, side branch as well as main branch.
Yeah.
Yes. The usual considerations that we would undertake in any bifurcation lesion.
Yes.
Actually, considering the left main stenting, three things we have to remember. One is the anatomy of the lesion, pathology of the lesion, and expertise and his choice. These three things will decide which technique we will consider in the left main stenting. I think it is still considerable.
Even then, if we, what Dr. Tan Hui Chim told, that if we consider double stent strategy from the very beginning, then it is wise to do DK crash if the anatomy and the lesion morphology permits.
Dr. Tan, thank you very much because your presentation was very excellent. Number one. Number two, in case of emergency left main bifurcation stenting strategy, if you go for initially provisional stenting, as you know, pull-out is a double provisional stenting. So in that situation, when you try to bail out the left main bifurcation stent procedure, whose technique you prefer?
Again, it will be very morphology driven. If I can just get away with a provisional approach, I would do that in an emergency, because to have a left main AMI is a big deal, and your primary objective at that sort of circumstance is really just to save life and not to restore a perfect anatomy here. So if I can get away with a provisional approach, this is what I will do in the left main PCI for emergency STEMI.
Here, our is Professor Afzal Rahman, sir. Sir, can you please make your comment, sir? Professor Afzal Rahman, sir.
Okay. Thank you very much. Thank you, Professor Tan Hui Chim. That's a very brilliant lecture, and I enjoyed the three speakers. They are really good. Hello.
You open your video, sir. Okay, sir. Thank you.
We can open, I think, sir. I think so. I will connect everything.
Yes,
so
sir.
I'm telling that thank you, Professor Tan Huisim, for your brilliant lecture. I enjoyed it. And the other speaker was really great. Nothing to say about that. And it was a very well discussed. So I think so nothing has been left. But one thing I can say that Leishman disease is no longer case is the disease of the CABG. So previously it was thought that the CABG is the gold standard for the Leishman disease. Now it is not gone. It is not right. Now you can do the PCI, especially in the low syntax score. It is better than CABG. And intermediate score you can do it. And if the syntax is higher, then you have to think that outcome may be the better in the CABG. Which treatment strategy is better, that will dictate the distal lesion, not the left main. It is the distal vessel disease that will dictate that either you will go to CABG or PCI. In the complex lesion, definitely if the CT is higher, then if you want to do it, definitely we have discussed with the patient and we have to heart tip approach. That's very important. And after a long-term outcome is most important. And I am 100% agree with the Tan Huisim that which technique you will use, it depends upon the lesion morphology. And your LCX, osteal lesion and XX proximal lesion will dictate that which strategy will you do. So your LCX is very important determination factor to doing the stenting strategy. Among the, definitely most of the lesion can be dealt with the provisional. That is 60%, at least somebody says 80% can be dealt with the provisional stenting. But if you want to do the double stent, definitely culotte is very safe, but TAP is a very simple technique. Among the two stent strategy, TAP is very simple. And you can do it very simply. And if you are a beginner, I can TAP maybe the better if it is suitable for you. And otherwise, culotte and somebody is doing the culotte is better. That is a different issue. But none of the trial and randomized trial say that which technique is superior. Some studies shows that the DCB is superior than the culotte, and some factor study does not agree with that. Even EBC trial says that still provisional stenting is the default stent strategy until the result is coming, that is EBC. Now it's coming to 2010. And in this trial, it will be proven that which strategy is better. Either it's culotte or DCB or provisional. Still, provisional stenting should be the default stenting strategy. And among the double stenting strategy, definitely DCB is my preferred strategy. Thank you very much.
Thank you.
So, Professor Sorabuzaman, do you have any comments, please?
Madam, I think he is not in.
Okay, good.
Not connected.
Can I say something? Just
Yes.
Prof. Chim, it was an excellent talk as usual. Nice to see you. You're evergreen like all the time. It is, you see, the evolution of the mainstem stenting. When we started it, it is mostly provisional. About 60%, 70-80% were provisional, maybe more than that. But gradually, as the FFR has come, then ultrasound has come, then OCT has come, then you can comfortably deploy the two stents, and you can evaluate what is happening, and the result is good, no doubt about it. Because before that, it was not possible. So even then, worldwide, even then, because most of the centers, those are not privileged, still the provisional stenting is the most common one. Here, I just want to ask you that, as it has already been asked, that in your practice, even nowadays, because these facilities are there, so you can do the double stenting. But as it is very important, before you embark on this, what you are going to do, which double stent procedure technique you will apply, that it depends on the lesion, no doubt about it. The lesion and the preparation of the lesion, and then the landing zone, then you can do the whatever crush you want to do or whatever way you want to do it. I think it has been highlighted very nicely. I thank the president and the secretary of this BCSI, Fazlur Rahman, and the Mir Jamal, and all the panelists globally as well as in our country, and everybody who are all listening. You start main stem doing when you are confident enough, and you discuss with your colleagues and fellows, and then gradually you will find out the technique you are used to and you're good at it. You will do that. Thank you very much.
Now I can draw attention, Dr. Colombo. Colombo, do you hear me? Dr. Colombo?
Probably left.
No, he's in his, still online.
Screen.
Okay. Dr. Ted, you know, 5th September, there is a wonderful article published in JACC, 5th September. The cohort study shows they use IVAS or image-guided procedure around 5.6% cases all over the United States. Now, what about your country? How much you use image-guided PCI, especially left-in bifurcation lesion?
I have to tell you that in left-main PCI, we use imaging liberally. So IVAS is preferred in a left-main setting, particularly if it's a diffuse left main. All other IVAS in left main, I have to say that the overall use of imaging is about now approaching 50% in my lab, because people are now very comfortable and very convinced of the role of imaging, whether it's OCT or IVAS, in optimizing the results of PCI. So I have to say that we are now approaching 40 to 50% use of imaging in our PCI. And I think for left main, with this mortality benefit, I will really encourage people to use it.
Thank you, Professor Chan. As we know that it is essential, but it is not mandatory. And in the guideline, till now it is class 2 indication, but as far as possible, if the availability of the IVAS or OCT, whatever may be, then we should use, and its result is good or better than without imaging. This is the fact.
Now, if you want to do the complex PCI double stent strategy,
yes, sir.
You should do I think so it is better to do or I would say that should do the imaging. If you do the provisional stenting, you can finish up with without IVAS. But in experienced officers, they are doing that. But I think so in our country, it is very difficult for the financial constraint.
Sir, without that,
can I ask?
Without financial matter, in USA, what Professor Azam has mentioned, only 5% cases, 5.6% cases, they use imaging. But in our country, how we will use routinely?
No. It is all over the world reflection. Azam explained it is all over the world reflection. Our country is less than 5%. In Japan, it is 100%. In Singapore, maybe the 50-60%, like that.
Yes,
so
yes,
it is a world scenario, not USA, maybe the 20 to 30%, because there is some reimbursement problem is there in USA. But in left main, it should be more. What do you think? Double stent strategy in the left main, especially culotte or decay crash, then I think so it is better to do the imaging. It is possible.
Yes, sir, I totally agree with Professor Afzal Rahman, sir, because which I tell you earlier, it is published in 5th September, this 5th September, in the code study in USA. They try to encourage to optimize their PCI outcome by using image-guided PCI. Overall, they are used 5.6% in US, sir. So they take several programs to improve their PCI outcome, and they enroll their IVAS program in almost all centers to improve or to increase the image guiding facilities. In our country, sir, definitely I agree with you. Our chance may be less than 5%, but in Singapore, in Korea, and in Japan, these far east countries are much more advanced, especially used in image-guided PCI. So far I know, whether I am right or wrong, I'm not sure. I think Professor Tan Hui-Kim can add some 1 point or 2 points.
Well, I think the adoption of imaging modality really depends on 3 factors. One is the healthcare system reimbursement in your respective country. You find that in systems where they reimburse freely, like in Japan, you see everybody use it. The second thing is, of course, the availability of training as well as experience. So you need a lot of mentorship, you need a lot of training for the people operators to be very familiar with the use of IBERS or OCT. And the third part of it is, of course, the availability of evidence-based results to guide the operator to instill confidence in the use. Certainly, in IBERS, we have enough data, at least in the left-main PCI, to tell us is useful. So OCT is coming in so far. So these three factors will really drive this sort of pattern of usage of imaging guidance in the respective healthcare systems. So perhaps Bangladesh, the biggest barrier may be the financial component of it.
Tim, can I ask you one more question? Is that this left brain stenting, whether provisional any technique you are using, the patients are diabetics, and those who are not diabetic, is there any follow-up? Is there any thing you have noticed as should take note of?
So we have a lot of argument about diabetic patients, oftentimes given the findings from Freedom Trial as well as sex diabetic subgroups. So I have to say that if you have left main multivascular disease, impact LV function, and diabetes, I think the heart team really sways towards coronary artery bypass surgery. But not all diabetics are the same either. So if you have a morphology that syntax score that is low and doesn't look like it's too complex and it's just isolated left main or perhaps one or two other vascular disease, you might still consider PCI. But it's always going to be a heart team discussion in that sort of situation.
So, Professor Tan, I also have one question. So, in your daily practice, actually, we all know that definitions 2 criteria is based on the anatomy and morphology of the vessels, and FFR is the functional study. So, in your daily practice, when you face whether we should do the 2 stenting for the left main, would you prefer to use the FFR to guide the strategy, or would you prefer to use the definition 2 criteria to guide the decision of 2 stenting?
I think when you have a left main bifurcation, sometimes it's a little bit challenging to do a FFR interpretation well. When you have so much disease going on, it's very hard to assess the left LAD or left complex. I have to say that in my daily practice, it's the image guidance modality that drive my strategy in terms of treatment choice.
Azam, Antonio is there. Antonio Colombo is there.
Yes, I'm here.
Yes, Professor Antonio Colombo, we want to have your comment on the speech of Professor Tan, left main bifurcation lesion.
But I think, as was presented, DK crash is most probably the most versatile. But if you do imaging and you are careful, I believe a culotte is a reasonable option. I think about the napkin ring figure. But maybe new generation DS are more versatile to be fully open. So maybe this napkin ring can be avoided. And culotte, even if you have some overlap, you don't really have to. You can do a mini culotte with minimal overlap. So I think. Even if I prefer DK crash, I do not believe that culotte is a mistake. I think if you are expert and you do imaging, you can do culotte with good result. That's my opinion.
Thank you, Professor Tan. Professor M. Azam.
Thank you very much, sir. Now I think it is the open discussion from Fazila Madam. If you try to initiate any raise any issue for discussion, Professor Fazila Malik.
Well, actually, I've been fascinated by the 3 presentations and I really thoroughly enjoyed myself. So if anyone has any further comments, then we can listen to them and we can ask our panel of experts. But if not, I think it's been a great session, and maybe it's time for us to conclude and say thank you again to our speakers. So I would request our Secretary General and our President to say some concluding remarks. And if you have anything to say, Azam, go ahead and make your views known to us, if you have any views.
Thank you very much, Madam. Dr. Colombo, we are really happy. Sorry, Abdul sir, would you like to make any comments, sir?
No, I think we covered the topic quite extensively. Nothing to add.
Okay, thank you very much. Now I am requesting Professor Mir Jamaluddin for conclusion and for the summary of the session.
Thank you, Professor Tan Huisim, Professor Antonio Colombo, and the late Dr. Shao Liang Chen for their brilliant speech. From the speech of our Antonio Colombo, we have learned regarding the small vessel angioplasty, tips and tricks, as well as the pathway in which we should go. And from the speech of Tan Huisim, one of the most complicated intervention is distal left main bifurcation, which is approximately 70% of all left main bifurcation. And he has shown very nicely the different procedures, what we do in our day-to-day practice, which one is better and why better. Everything he has mentioned very nicely. And in our definition trial, he has also shown that decay crash, one of the difficult, but not difficult for those who are doing regularly, the decay crash, and the result of which is better than other procedures. And he has shown the different studies and the results of decay crash. And all the panelists from abroad, and as well as from my country, we must congratulate you, thank you, as because you have given the time, and we have learned many things from you. Don't forget to join the next program on 9th October, BSCI Virtual Summit. This is our next program. So I am inviting in the program of virtual conference on 9th October, BSCI. And where we will discuss mostly left main, bifurcation, CTO, tip cases, mostly a case-based discussion. And finally, what progress we have made so far in our international cardiology field, what and how can do better to improve outcomes, how can we address the unmet need in complex intervention. Now I want to request our panelists, our executive committee members, if they want to have any comment regarding the session, they can contribute. If Professor Abdul Wadud Chaudhary, Professor Mamunur Rashid Cesar, and so far I think all have enjoyed the program, and after a good enjoyment, they have left. So we are very much happy to have the session, and we are grateful to all the three speakers for their learned speech, by which we have learned many things. Now I want to say that our Professor A.K.M. Fazlur Rahman, President, Professor BSCI, will conclude the session. Before that, I want to tell that my executive committee of BSCI, they have given us maximum time for giving this opportunity to make the conference success. And we are grateful to them, as well as we are grateful to all of the participants. Thank you. Thank you all. Professor A.K.M. Fazlur Rahman. Unmute you. Unmute you. Unmute you. Thank you.
So thank you very much, all participants, panelists, and honorable speakers. Actually, it's a great pleasure for us to have you, all of you, with us. I think it is a very, very interesting and beneficial program. Especially Dr. Colombo, he has described the use of drug-eluting balloon in present era. Dr. Tan, he described all the technique and which one is better, which one is not better, which should be considered, which should not be considered. We have learned a lot from his lectures. And Dr. Xiaoling, he gave a new direction in considering the bifurcation lesions, especially in the left main, giving emphasis and decay crash. I think it is very, very beneficial program. I hope we will do the same in our upcoming program on 9th October in BD Intervention 202. I invite all of you to this program. So many thanks all the participants, all panelists and speakers from home and abroad to join this meeting. Thank you all.